So let's change gear in the next few slides. Let's talk about the antagonists, adrenergic antagonists or sympatholytic drugs. Alpha antagonists result in relaxation of the smooth muscles. So result in prominent clinical effects of hypotension, orthostatic hypotension, tachycardia, meiosis, nasal stuffiness, diarrhea, and inhibition of ejaculation. Phentolamine is a prototypic drug. It's an IV drug, very expensive, and used primarily in pre-op treatment of pheochromocytoma or intra-op treatment of pheochromocytoma. It's a competitive antagonist at both alpha 1 and alpha 2 receptor, and its most common side effects are cramping, diarrhea, tachycardia, and hypotension. It causes vasodilation very quickly, so your blood pressure drops within 2 minutes, and it lasts about 10 to 15 minutes, so short-acting drug. And when you get this blood pressure drop, you get the baroreceptor reflexes going into effect, and norepinephrine release as a result. Phenoxybenzamine is the PO equivalent of the phentolamine, and it's again non-selective alpha adrenergic antagonist. Its alpha blockade is about 100 times more potent on postsynaptic alpha 1 receptor than the alpha 2 receptors, though. So, especially in patients that have hypertension or hypovolemia, pretty much everybody get orthostatic hypotension when adequately treated. Cardiac output is often increased. Renal blood flow is not affected. Coronary and cerebral vascular resistance is not affected. So that makes it a particularly ideal drug to treat the FEO patients as outpatients. Prazosin is a relatively selective for alpha 1 receptor. It's less likely than the non-selective antagonist to evoke reflex tachycardia. It dilates both arterioles and veins, and cardiovascular effects include decrease in systemic vascular resistance and venous return. And when you combine it with a diuretic, it's a very effective antihypertensive drug. And it also can cause a little bit of bronchodilation. Doxazosin and tamsulosin are selective alpha 1 blocker that are used primarily for BPH and hypertension, and their most common side effects are orthostatic hypotension and dizziness. Done with alpha, let's talk about beta. Propranolol is the prototypical beta blocker. It's non-selective for beta 1 and beta 2, but does have some membrane stabilizing activity at higher doses especially. It's highly lipophilic, and its hemodynamic effects include decreased heart rate and contractility, as you can imagine. Also decreased renal renin release, and systemic vascular resistance may increase acutely from the beta 2 receptor blockage. And when you give it chronically, you get decreases in SVR. And this is secondary to the decrease in renin release and probably decreased central sympathetic nervous system outflow. And some complications associated with propranolol include bradycardia, heart block, worsening of CHF, bronchospasm, and also a little bit of sedation. And metoprolol is the more selective beta 1 blocker, and particularly useful in patients with reactive airway disease because propranolol can cause bronchospasm in them. Atenolol, similar to metoprolol, it's fairly cardioselective, fairly beta 1 selective, and its elimination is primarily renal. And the reason atenolol is particularly popular in outpatient is you can give it once a day, so patients actually take it. Esmolol, we all use it, we all love it. It has rapid degradation by esterases in the red blood cells. It's beta 1 selective, like metoprolol, and appears to have little effect on bronchial or vascular tone. It's markedly inhibited by sodium fluoride. One of the common questions I've seen in exams. It can blunt the response to intubation, and it's pretty effective in treating post-op hypertension. But you got to keep in mind the duration of action. Don't just give it and drop the patient and pack you. Peak beta blockade appears to occur within 5 minutes, even though the onset is much quicker. And when you stop an infusion, serum levels decline with an elimination half-life of about 9 minutes. So it has a pretty reasonable context-sensitive half-time. Timolol is a drug you often see that in terms of drops that the ophthalmologists like to use. It's a non-selective beta blocker, and it's the only beta blocker used as an L isomer rather than a racemic mixture. So it's 5 to 10 times more potent than propranolol, and when the ophthalmologist gives it in eye drops, it can actually be absorbed systemically and cause bradycardia and hypotension that are refractory to treatment with atropine. And this can be a long-lasting effect. Labetalol is the antihypertensive drug with blocking of both alpha and beta receptor. And relative alpha to beta blocking effects are dependent on the route that you give. So when you give it orally, the ratio of alpha to beta is about 1 to 3. When you give it IV, this ratio is about 1 to 7. And this is why some books say the ratio is 1 to 5 when you give labetalol, when they don't say oral or IV. But this is the correct one for the most part, 1 to 3 for oral, 1 to 7 for IV. And this means just the ratio. And the effects are primarily on alpha 1 receptors, whereas the beta effects are non-selective. So it results in decrease in peripheral vascular resistance, decrease or unchanged heart rate, little to no change in cardiac output, and decreased renin activity. So when somebody is hypertensive with systolics of 200 and diastolics of 110, heart rate is 30, would you give labetalol? Let's talk about this during lecture, and if I forget, somebody please remind me. Elimination is not markedly prolonged in patients with hepatic or renal failure, so that's why it's very useful in our practice. You don't have to think about those sick patients in terms of labetalol lasting forever. And there is an enhanced effect of labetalol by inhalation anesthetic and a little bit also by propofol. So in this table, a very high yield section for test question is the relative selectivity for beta 1 receptor. And here you can see propranolol and timolol are not selective for beta 1, but metoprolol, atenolol, and esmolol are highly selective for beta 1 receptor as opposed to beta 2 and have similar specificity.